Okay, this paper is about the link between idiopathic intracranial hypertension and fibromyalgia and chronic fatigue syndrome. So it's often abbreviated IIH, idiopathic, meaning of unknown cause, intracranial, inside your skull, hypertension. So there's high pressure in your skull. Well, why would that happen? And here's the big secret. It's mostly because people are fat, especially fat females, but it can happen in fat men as well. And sometimes it can happen in people who aren't that fat, but the bottom line is don't be fat, okay? And how do you don't be fat? Eat low-fat vegan with no oil, all right? So let's talk about it, though, because I do see this occasionally. You know, one of the things I do is I'm a neuroradiologist, amongst other things. It's by definition with an intracranial pressure greater than 25 centimeters of water in a fat person, okay? 90% of the patients are females. I'll show the pictures of all these physical findings so it'll make more sense. They often have headaches, cognitive slowing, sympathetic overdrive. They're in a bit of a more sans than pan sympathetic autonomic nervous system, which is the fight or flight, adrenaline and cortisol, stress, or in other words, rather than parasympathetic relaxation. Some papers say they think that it could be due to transverse sinus stenosis, but I'm going to tell you there's a good reason why that's overrated. And I think the main cause is a big belly pushing on the cava, inferior vena cava. I'll show you why. And that's going to drive up central venous pressure, going to drive up intracranial venous pressure. Okay, here's the paper right here. A link between idiopathic and intracranial hypertension. Okay, so here's the big mystery, okay? When a person's fat, their big fat belly pushes downward on their inferior vena cava in the abdomen. This is the big vein in the abdomen, inferior vena cava. And then that pressure will flatten it out. Instead of being round like a beach ball, it gets flattened like a little football, okay, a deflated football. And this pressure down on the inferior vena cava is transmitted through the right atrium on up into the superior vena cava, which is the vein. So the inferior vena cava drains the legs into the heart and the abdomen into the heart. Superior vena cava drains the brain, the arms, and the neck down into the heart, okay, into the right atrium of the heart. When you have elevated IVC pressure, because of the big fat belly pushing on the inferior vena cava, it's transmitted to cause elevated right atrial pressure, which is transmitted to cause elevated superior vena cava pressure, which is translated to cause increased jugular vein pressure, transmitted to cause increased intracranial venous pressure. When you have increased intracranial venous pressure, then you're now not able to absorb cerebrospinal fluid from out of the cerebrospinal ventricular system and subarachnoid space into the arachnoid granulations on top of the brain. So the bottom line is you don't absorb CSF well when your venous pressure is high. And that's going to cause back pressure all over the place in the brain and the spine. And I'll show you what that's all about. And I'll show you what happens to these patients. So first of all, just to give you a simplified sense of venous intracranial hypertension. So the white stuff, this is a T2 weighted image. T2 in MRI just means CSF is bright. So the CSF being under increased pressure is going to push down on things. It's going to push down. This is a normal pituitary in a female. It's kind of round, looks about the size of a dime. Okay, here the CSF pressure is pushing on top and it's flattening out the top of the sella. So that's called partially empty sella. Sella means like a horse saddle, like sella turcica, Turkish horse saddle, because the pituitary sits inside like a saddle. Okay. When it's more severe, you get additional flattening of the pituitary. So this is called more of an advanced empty sella. But empty sella, to some extent, is a bit exaggerated. Again, about the only difference you can rapidly see looking at a female brain versus a male brain is a premenopausal female's got this big honking pituitary. That's why they're so emotional. That's why they have a menstrual cycle. Okay, their brain is not the same as a man. It is biologically different than a male's brain. I can tell from across the room that is a premenopausal female. That is a male. I can tell, okay? And that's the only obvious finding. All that stuff about the corpus callosum is not so readily apparent. Okay, so anyways, what I'm getting at, though, is in a man, men routinely look like this. You can have a 100% normal guy, and he'll look like this. You can show me 10 men in a row, and their pituitaries will look like that. So that finding is not reliable in men. I'll also take a look at this cerebellar tonsil to see if it's projecting down below the foramen magnum, the so-called Bassiano-Pistheon line. Okay. Now here's a summary slide of the findings in idiopathic intracranial hypertension. Number one, the partially empty sella appearance, of more significance, of course, in a man. Number 2, you can see the cerebellar tonsils of the cerebellum are projecting slightly downward. The anterior margin of the foramen magnum is called the basion. The posterior margin of the foramen magnum is called the opistheon. So from the front to the back is called the BO line, basiono-opistheon line. And these tonsils are just a little low. So that would be called just mildly ectopic cerebellar tonsils, which by themselves are usually asymptomatic, but in the context of a partially empty cella and other findings suggestive of IIH, idiopathic intracranial hypertension, you might go ahead and suggest a diagnosis, okay? You can see here the cerebral spinal fluid around the optic nerves is quite prominent. You can also see it's a subtle finding, but the optic nerve at the fovea, the macula, so to speak, it's bulging into the ocular globe. That's a no-no. That's not supposed to happen. So that's abnormal. Okay. Sometimes we'll see flattening. Here you can see flattening of the posterior ocular globe. That is also abnormal. Now the next finding is the most important one, but there's a major pitfall here. This is a time of flight TOF type MRV, magnetic resonance phenogram of the brain. And what this arrow is pointing to is transverse sinus stenosis is the implication. But I'm going to tell you, I've looked at many thousands of these, and on time of flight, you almost always get an artifact right there at the junction of the transverse sinus and the sigmoid sinus. So this is not a reliable finding. There's a much better sequence to look at. What you want to do is get a post-IV contrast coronal, T1 post-IV coronal MRI of the brain. It's often done on what is called an MPR sequence, multiplanar rage sequence, but a standard T1 conventional coronal image, T1 post-IV contrast, that'll give you a good image. And if the transverse sinuses are flattened down, it has to be bilateral. If it's unilateral, that could just be normal variant. I see that all day long every day. But if it's bilateral and they're flattened down, that's an indicator that the patient probably really does have idiopathic intracranial hypertension. Pierce Morris has a great lecture this summer on the internet. He's this great neurointerventionalist over at, he was at the Mayo Clinic. He was at Harvard before that. He wrote a great textbook on neurointerventional radiology. Okay, so yeah, we covered those findings. Now here I'm just showing you again what does that look like. So here's normal with a wide open transverse sinus junction of sigmoid sinus, okay? And here's what is described as being transverse sinus stenosis, okay? But again, I see artifacts there so often. I expect to see an artifact there. So I really am not very confident in calling stuff on this time of flight type MRVs, magnetic resonance phenograms. I really want a post-IV contrast, okay? So I can confirm it and believe it. It's a big deal to make the call because they might go ahead and put a stent in there. You don't want to have a normal vein and then have them go in there and do a venogram of the patient's brain. They go, it was normal. Why'd you call it abnormal? They go, don't you know that's an artifact? No, you don't want to look like an idiot, You could also do a CT venogram. Okay, so now we're also going to show, here's a normal looking brain, a coronal T1, and you can see the smooth outer surface of the brain. Whereas in an idiopathic intracranial hypertensive patient, they've got meningoceles, little herniations of subarachnoid space into the skull around the bone. You don't really see the bones too well because this is an MRI. But what's happening is CSF arachnoid granulations, they're eroding into the bone. Here's a CT scan, and you can see a little hole in the bone. It's eroding into the bone. Here's a hole dug into the bone by the arachnoid granulation. Here's erosion of the arachnoid granulation into the skull base, into the the greater sphenoid wing. Here's other additional erosions of the cerebral spinal fluid into the sphenoid wing. These are called little meningoceles. Here's a meningocele, okay? So these are characteristic findings. Here's, again, little erosions, okay? Characteristic findings of idiopathic intracranial hypertension. So you see these all together, you suggest a diagnosis, okay? Here's a little bit, they're calling this a dilated cerebral spinal fluid CSF sheath around the optic nerve. It's really not that bad. I would actually consider that within normal limits. There's a hint of flattening, but I prefer to look at it on the axials because that's what I'm used to looking at. Okay, here is a T1 post, and there's a little bit of enhancement of the optic nerve head, and there's also a little bit of inversion. It's bulging into the ocular globe. That's abnormal. That should not happen. It'll also sometimes have abnormal increased signal in it on the DWI sequence, diffusion weighted imaging sequence, which a normal optic disc will not have. And you can have papilledema, which means elevated pressure within the optic nerve head that they can see when they look through an ophthalmoscope. That's another manifestation of idiopathic intracranial hypertension. The patient might have visual blurring. They'll often have headaches. So these are other characteristic findings. So like I'm saying, that transverse sinus stenosis is a big deal because some papers believe that's the causative mechanism, and they will put a permanent metal stent in that location. And what I'm trying to say, if the patient has a brain in their head, do not mess around. Go low-fat vegan, no oil, lose the darn weight, the belly will drop, you'll drop the pressure on the IVC, you'll drop that transmitted pressure, and you got a very good chance to cure yourself rather than end up with all these additional problems. Okay, and then how does it get associated with fibromyalgia? Because the increased pressure is going to cause overdistension of the CSF sheaths that accompany the nerves as they exit the neural foramina from the spine, and that can cause irritation in the nerve roots and cause pain. They can get all these weird, vague pains, as is characteristic of fibromyalgia. So this is what it's all about. So what I just did was I gave you the combined mechanism of idiopathic intracranial hypertension as well as fibromyalgia, and some believe that this is even associated in some cases as a potential cause of chronic fatigue syndrome, and that it can cause cognitive slowing and headaches and mental slowing and cognitive impairment. So, there's different things that can cause chronic fatigue syndrome, but all I'm saying is this is a potential danger of being fat. Increased intracranial pressure, which over time is going to lower your cognitive function and is going to potentially cause you all these problems. So don't mess around. Go low-fat vegan, no oil. Anyways, I hope you found that interesting. I think that's the last slide there. Let's see. Yep, that's it. So hope you found that interesting.